I'm really proud to introduce the panelists for the Tobacco Control for All, Addressing Smoking Disparities for Priority Populations. The moderator and discussant for this panel will be Linda Alexander, PhD and EDD, Senior Associate Dean for Academic, Student, and Faculty Affairs, Professor of Social and Behavioral Sciences at West Virginia University in Morgantown, West Virginia in the USA. She'll be starting us off with a brief overview. We'll move on to Jeffrey Fong, PhD, Professor of Psychology and Public Health and Health Systems at the University of Waterloo, Ontario, Canada, Senior Investigator of the Ontario Institute for Cancer Research in Toronto in Canada. Next, we'll have Pebbles Fagan, PhD, MPH, Professor of Health, Behavioral, and Health Education, and Director of the Center for the Study of Tobacco at the University of Arkansas for Medical Sciences in Little Rock, Arkansas, in the U.S. Next we'll have Andrew Wah, MPH, Ngati Hine, Senior Research Fellow in Public Health, Co-Director of Aspire 2025, Eru Pomare Maori Health Research Center in the University of Otago, Wellington, New Zealand. And finally, last but not least, we have Monica Webb-Hooper, PhD, Professor of Oncology, Psychological Sciences, Family Medicine, and Community Health, Case Western Reserve University, Associate Director for Cancer Disparities Research, Director of the Office of Cancer Disparities Research, Case Comprehensive Cancer Center, Cleveland, Ohio, in the United States, and co-chair of the SRNT Health Disparities Network. Can you please come up, panelists?
Good evening. I'm Linda Alexander. The conference planners selected this presidential symposium to highlight those left behind in tobacco control. Those of you in the audience with an authentic purpose know that tobacco is a major cause of premature and preventable death worldwide, killing over 5 million people. A recent WHO executive summary dictates global success in tobacco control in countries from Afghanistan to Zimbabwe, but highlights tobacco industry interference with government attempts at regulation, policy, and prevention aimed at reducing the destructive practice of tobacco use. This evening's session will provide more detail about this phenomena and other facts connected with tobacco control in the U.S. and abroad. I had the honor of working with Dr. Fagan as the scientific advisor and Dr. Webb-Hooper as an author and chapter editor for NCI's Monograph 22, which is focused primarily on tobacco and tobacco-related health disparities. Although aimed at understanding tobacco disparities for priority populations in the U.S., the comprehensive literature review commissioned as part of that process revealed significant gaps in our understanding of the burden of tobacco for several unique, vulnerable, and marginalized populations. Clearly, our work is not done. One of my roles as the senior volume editor of the monograph was to pen the introduction, including the monograph's major conclusions. I wrote, since the publication of the 1985 and 1998 Surgeon General reports on cigarette smoking, little progress has been made in understanding the individual, interpersonal, community, and societal policy determinants of tobacco-related disparities in racial, ethnic, and socially disadvantaged groups. When the draft came back from clearance, that sentence was altered to read, "Tremendous progress has been made in tobacco control over the last 50 years, but some groups have not benefited equally. Clearly, some reviewers and I had a different perspective on where to put the emphasis. Celebrating progress in tobacco control is important, but cheers and applause should not deafen the cries of those not reached by our efforts. Doctors Fagan, Wah, Fong, Webb-Hooper, and I worked with the session chair and her team to put the correct emphasis on our title, which highlights the importance of tobacco control for the inclusive groups affected and the importance of making certain that our policies, programs, and education impact all. The celebrated motivational speaker, Simon Sinek, suggests that to make an impactful difference, strong advocacy and leadership should start with why. The compelling messages you'll hear from our panelists will help answer the question why. Why should we continue to examine our current epidemiological surveillance systems in our efforts to reach those behind? Dr. Fagan will challenge our current assumptions about how we use information in those systems and whether or not researchers, policymakers, and funders are asking the right questions. Why should we revise our thinking about the tobacco endgame? Dr. Wah will highlight research in New Zealand to provide you with critical thinking around more scalable and radical efforts at the population level in tobacco control. Why should we re-examine the effectiveness of individual-level approaches for tobacco prevention? Dr. Webb-Hooper will provide evidence that current approaches have not benefited some groups owing to those left behind, and as new tobacco products enter the consumer marketplace, we may need to rethink certain prevention practices. Why is it important to understand the differences in the impact of tobacco control policies between low-income and high-middle-income countries? Dr. Fong will discuss important nuances in warning labels, packaging, and smoke-free laws that may have implications for the health equity lens as defined by his research priorities. Why should up-and-coming researchers, scientists, students, and new investigators seek to work in the area of tobacco disparities? Because we currently do not have tobacco control for all. SRNT has maintained a focus on tobacco control for all in this symposium, and presentations through Saturday, including keynotes by Dr. Eliseo Perez-Stabo and Dr. Kelvin Choi, look for the answers to some of the questions inspired by our panel in those talks as well. So let's begin and keep the whys in mind. We ask that you hold all of your questions to the end, and we fully expect a rich dialogue inspired by these panelists. Please welcome Dr. Fong to the podium for our first presentation.
Thank you very much, Dr. Alexander. It's a pleasure to be here today. It's a wonderful city. I grew up down the peninsula, and it's so wonderful to be back with all my colleagues. I am going to talk to you about the ITC project, but in a slightly different way. I'm going to be talking about the impact of FCTC policies, that is the global treaty on tobacco control, and the differences between the impact of these policies in high-income countries versus low- and middle-income countries. But I also want to examine the differences within a country of the impact of these same policies among high-income versus low-income groups. And I have a couple of methodological points to make along the way. So let's get started here. Those are my disclosures. And the global tobacco epidemic, as you may know, here are some important statistics. 7 million deaths a year, including another over 1 million deaths from secondhand smoke. And the burden, as we know, is shifting from high-income countries to low- and middle-income countries. And of course, we know that tobacco is not just a health problem, it is a problem of astronomical economic burden. And from the WHO NCI monograph and also from follow-up work from WHO, we know that the total economic cost of smoking per year is 1.4 trillion US dollars. That's 1.8% of the global GDP. And 40% of this cost is in developing countries. Now, developing countries do not account for 40% of the world's GDP. So their burden is considerably proportionally greater, and that's only going to get worse as the century progresses. The FCTC, the Global Treaty on Tobacco Control, it's been ratified by 180 countries and also the EU separately. It's multi-sectoral. It recognizes the fact that tobacco epidemic is not just a health problem. It also includes and obligates these parties, the 181 parties, to implement strong evidence-based policies such as pictorial warnings, higher taxes, measures to reduce illicit trade. And the tobacco industry, in a very important article, Article 5.3, says it says that the tobacco industry must be prevented from influencing policies and measures. Given the fact that this is a worldwide treaty covering about 90% of the world's population, addressing the #1 preventable cause of death, I think that this next statement is not controversial. This is the greatest disease prevention initiative in history. So we have some evidence showing that when countries implement policies, when they implement these FCTC policies at the highest level, there is a corresponding significant decrease in smoking prevalence. You can see that we published this a couple years ago, 126 countries. On the x-axis, you can see that that is the number of policies, key demand reduction policies that were implemented in the first decade of the treaty. And the corresponding numbers on the y-axis is the reduction in smoking prevalence. And you can see that significant impact. So we know the FCTC works. The problem is implementation is very, very slow and weak at many times. So the ITC project, we created this in 2002, and it's grown from 4 countries to now 29 countries. Our 29th country is Japan, where we are looking at heated tobacco products and how they interact with cigarettes. So we're doing that right now in Japan. The objectives of the ITC project are to evaluate FCTC policies, to answer or address the issues, questions of are pictorial warnings more effective than text only? Do higher taxes lead to lower smoking rates? Do total smoke-free laws work better than voluntary guidelines, and so on? And do that across our 29 countries over time. We compare the impact of these policies across different countries, and so that part of my results are going to look at the cross-country differences there. We also, of course, communicate. We have a large, strong dissemination program on this, and we build capacity all over the world, including in LMICs. We also we're the first and still the only international cohort study of tobacco use. We have national samples in most of these countries. We have a conceptual model that specifies the pathways going from policies, what do they change in the individuals to lead to behavior change, and what are the impact of that behavior change. Many of our evaluation studies of the ITC project employ quasi-experimental designs, difference in difference designs. So we are in 29 countries, including these top 10 countries, China, India, US, Brazil, Bangladesh, Germany, and the latest one is Japan. That's 7 of the top 10 countries for smokers. And we cover 50% of the world's population, 60% of the world's smokers, and 70% of the world's tobacco users. The 2 major questions I want to address here in this Disparities Symposium is the following. We are asking between country questions. Do tobacco control policies in LMICs have different impact than those same policies in high-income countries? And for example, do graphic warning labels and comprehensive smoke-free laws work as well in LMICs as they do in high-income countries? And also, we're asking the within-country question. Does the effectiveness of tobacco control policies vary across equity groups? So, for example, income. Do graphic warning labels and smoke-free laws work as well among low-income SES equity groups as they do among high-income SES equity groups? Do these policies benefit low equity groups at all? So these are the questions that we're asking in this analysis. So I want to go through some cross-country comparisons for Article 11, packaging and labeling, and this would be the adoption of pictorial warnings where before they were text only. So this is a graph that's a bit hard to, and you probably can't even read those, and I can't even read them here. So you'll just have to trust me on this. So you notice, you can all see the colors, okay? So let's start there. The colors on the top are the blue. The blue colors are the high-income countries, and this is the measure that we use, which is salience of health warnings. So the pictorial warnings are here, and within the high-income countries, the text only are there. They're slightly faded. So you can see here that salience of health warnings among the high-income countries, pictorial is higher than text only. And the difference between those bars is pretty significant. Then if you go with the low and middle income countries, pictorial warnings and then text only, you also see the fact that the salience is significantly higher for pictorial, but the effect isn't quite as great as in the pictorial warnings versus text in the high-income countries. But note here that warnings of any kind in the low and middle-income countries has stronger salience. And the reason for this, we suspect, is because in low and middle-income countries, there are fewer other sources of information about the harms of tobacco. So therefore, these warning labels represent a greater proportion of their total information about it. That's why you get this effect of low and middle income countries. Warnings have a higher effect than in high income countries. Here's another measure for going a cigarette due to warnings. We have the pictorial warnings versus the text-only warnings. You see some effect. Pictorial is better than text-only there, and also in the low and middle-income countries, you see, if anything, a stronger effect with pictorial warnings leading to smokers reporting that they actually didn't smoke a cigarette they were going to smoke because of the warnings, which is a sign of a later quit attempt. So in both of these cases, the effect of warning labels and the policy is stronger in LMICs than it is in HICs. So the second one is with smoke-free laws. And we have a whole bunch of measures of effectiveness for smoke-free laws. We ask smokers and also non-smokers in most countries, the last time you were in a restaurant, was there any smoking? The last time you were in a bar, was there any smoking? What about your workplace? Was there any smoking in your workplace? So we have pre-post measures of this across many different countries. And what you see here is that in each of the countries, and these are Ireland, from left to right, it's Ireland, Scotland, France, Germany, Netherlands, Mexico City, Mexico, and so on. You can see the smoking levels in restaurants is dramatically lower after the implementation of a comprehensive smoke-free law. You can see all that, and then you get to some of the other low and middle income countries, and you can see Mauritius there, which is why Mauritius is the one before Japan, and you have a fairly good effect. But you can see China there with partial smoke-free laws, which is in red there. It's not coming down very much at all, except for Beijing, which had a significant first city to implement a comprehensive smoke-free law. You can see that's gone down. So what we get from this is that strong smoke-free laws in high-income countries, it almost vanishes in restaurants. And Korea more recently went from 69 to 11%. In China and Japan, with smoke-free laws that are not at all total, the impact is the smoking in restaurants is still very high. So now, looking at the cross-country comparisons here, you can see here there's a partial ban for the high-income countries, versus a comprehensive ban, you can see with the exception of Greece there, which is always quite strange. Greece is the big line, the solid line. Things are not happening in Greece, even though they're implementing strong laws on paper, but the enforcement and compliance is very terrible. There, you see comprehensive law has less smoking in restaurants than in partial bans. But in low and middle income countries, you can see here the partial bans, there's a huge amount of smoking still, and the comprehensive ban is very strong in those countries, LMICs, that have implemented them. So the impact of it is much greater because you started off from a much higher level of smoking. Smoking in bars, you see basically the same thing, although not quite as much. Comprehensive ban, the smoking levels in bars is lower than it is with a partial ban. And with LMICs, you see the same thing with the partial ban still having much higher levels of smoking, but not as strong as the restaurant effect. Now, turning to the individual level within individual countries, I want to address the issue of whether effects of policies differ by equity group. Now, we know from a number of reviews that there is oftentimes, almost always, a partitioning, identification of three types of equity effects. Positive equity effect means that the gap between, let's say, low and high income gets smaller when a policy is implemented. Negative is the opposite. The spread is greater, the gap is greater. And zero equity effect is when there's no difference in that. But what I want to do is I want to show you that the way that this is characterized is not the kind of situation that really captures the impact of these policies on equity groups. So when you say non-equity group, what comes to your mind? Well, here, high, middle, and low, when the policy was implemented, no difference, right? Parallel lines. Or, so the gap is about the same. So that's what you think about. But what about this? All three groups get the same amount. Oh, that's zero equity. You know, if you're a policymaker looking at zero equity, you go, I'm not touching that. That's not closing the gap. But I would argue that this is pretty good because the low equity group is getting something from it, and just as much as the high. So it's not the interaction. There's something more to it than that. Negative equity. Here's what comes to mind. Oh, the highs are getting something, but the lows are not. They're getting something worse. Right? The gap is widening. Or this, the highs are getting something, but the other two are getting nothing. The gap is widening. That's terrible, right? Oh, but what about this? You get a fan effect. So the lows are getting something significant, but the highs are getting even more. I would argue that even though the gap is widening, this is really great for the low equity groups. They're getting something from not as much as the highs, but do we care about that? That's a question we need to ask ourselves. So positive equity effect, you know, this comes to mind. This is great because the lows get more than the highs. But it could also have been this, where they're not getting anything. The gap is narrowing, but oh, you wouldn't want that intervention. But that's called positive equity. So what we find here is that with our actual data with restaurants, you find that basically everyone, this is zero equity effect in Ireland, zero equity in South Korea. And actually there's a negative equity effect in Mauritius because it turns out that the lows are getting less of an effect than the high incomes. I would argue this is a great policy for everyone. It's not the gap in the interaction. There's something else going on. So here's what I would like to, and I'm almost done. I've got about 3 more slides. In Malaysia, here's, I think, perhaps a more complete way of thinking about the effects of interventions on equity groups. So we have a whole bunch of outcomes for warnings in Malaysia when they went from text to graphic. There is a main effect on all of these. We care about main effects because the whole population on average got something out of it, and it's highly significant. And then the second part is you look at the simple effects. Did the lows get something out of it? No, they got 4 out of the 8, or 4 out of the 8. The middles got 6 out of the 8, and the highs got 7 out of the 8. But the lows got a lot out of this. So the means matter. Those were the main effects and the simple effects. And then here is the equity effects. They're all negative, almost all negative. So it's not the interaction, it is the main effect and the simple effects. So we have a whole bunch of other things like this. Gave up a cigarette due to the warnings. That's a negative equity effect there, but it's really good. So the conclusions are that between countries, we know from the NCI WHO monograph that for tax policies, LMICs benefit from this at least as much as high-income countries, perhaps even more, and then banning marketing activities leads to larger reductions in LMICs than HICs. And then within countries, policy impact does vary across different income levels, but there's evidence for some systematic differences here. FCTC policies seem to have about the same impact in low equity groups as in high equity groups. And there's a need to clarify the criteria for making conclusions about this, and I've suggested that we don't look at the interaction only, we look at the main effects and the simple effects. How important is it to close the gap versus ensuring that low equity groups are gaining in the simple effects? And then there's a need for us to look at these policies with an eye toward what is it about these policies that may have differential effects or the same effects across these equity groups. So anyway, I just wanted to thank you very much for your patience and consideration. And here are our research organizations and research support, and here's the major support for the ITC project. Thank you very much.
Good evening, everyone. Thanks again for coming to this opening session for SRNT. And what I'm going to briefly talk to you about is the health disparities that I have come to know in the over 20 years of research time that I've spent focusing on tobacco-related health disparities. So I want to do two things, which is to discuss how we have used our surveillance systems to identify and address tobacco-related health disparities, and discuss the next steps for surveillance and evaluation systems. Now, I've given numerous talks that describe what these disparities are using multiple data sets, but I'm going to take a different approach tonight. So let's just go back to some of the basics. We know that the goals of comprehensive tobacco prevention and control are to reduce initiation and prevent initiation among youth and young adults, promote quitting among adults and youth, eliminate exposure to secondhand smoke, and most importantly, identify and eliminate tobacco-related health disparities among population groups. So how do our surveillance systems help us to identify and eliminate tobacco-related health disparities? Well, we have to go back to the purposes of our surveillance and evaluation systems. We utilize our national, state, local surveillance systems to monitor things such as attitudes, behaviors, and health outcomes. We also compare the data to understand the magnitude and the scope of the problem among and between different population groups. We use the data to direct attention to particular health issues in various communities that need immediate attention. And we also compare the data to help us understand program and policy impacts. So, what do our monitoring systems do? What have we not done? And how do we use the information to direct policies and programs? But before we go into that, let's first talk about what tobacco-related health disparities are. Some of you were born in 1954 and probably remember the Hammond and the Horn paper that was published in JAMA that investigated the relationship between human smoking habits and death rates. Now, I know you can't read this. This is from 1954, okay? But one of the things that they were interested in doing is to look at smoking and death rates by occupation and urban and rural geography. They found that a greater prevalence of smoking and heavier smoking was among males in urban versus rural areas. And then when the 1964 Surgeon General's report was published, we knew at that time that over 40% of Americans smoked cigarettes and nearly 60% of African American males, 50% of white males smoked in the US. And we also knew that from Surgeon General Burney, that he had hypothesized that there were differences by gender and socioeconomic status. So understanding health disparities is no new issue to us, but it was not until the 1985 and 1998 Surgeon General's reports when we began to really dig into the issues focused on occupation and the relationship between smoking and lung cancer, and then tobacco use among racial ethnic groups. In the 1998 report, one of the conclusions was that rigorous surveillance and prevention research is needed on the changing cultural, psychosocial, and environmental factors that influence disparities. So we know that there was a call and an existence of these disparities as far back as 1954. It was not until 2002 when a comprehensive definition of tobacco-related health disparities was developed, but the Centers for Disease Control was doing this work before that time, and in fact, they have one of the longest funding initiatives related to disparities called the National Networks. So at a conference back in 2002 that many people in this room co-sponsored, over 20 people helped to develop the definition of tobacco-related health disparities, and this is really important. We defined it as differences in the patterns, prevention, and treatment of tobacco use, the risk, incidence, morbidity, and mortality and burden of tobacco-related illnesses that exist among population groups in the U.S., and related differences in capacity and infrastructure, access to resources, and environmental tobacco smoke exposure. Well, at the time that we developed this definition, there were some fundamental assumptions that we thought that we were all on the same page with, and which are that disparities are not mere differences between groups along the tobacco use continuum from initiation to health outcomes, because what is unequal is not necessarily inequitable. A difference may suggest that one group is more vulnerable to tobacco use than another, but it may not be a disparity. Disparities are associated with social determinants of health such as poverty, marginalization, civil rights, which make the observed differences inequitable. They are cumulative across the life cycle, representing a chain of events, often beginning with social indicators of disadvantage, and result from historical injustices that are avoidable and can be ameliorated with policies that target the health indicator itself or the social determinants associated with those disparities. So, are we monitoring tobacco use behaviors that provide insight to disparities, such as ceremonial use of tobacco use among American Indian and Alaska Native populations? Well, it wasn't until 2013 that we began to monitor tobacco use among LGB groups. And this was done with the National Health Interview Survey by asking the question, which of the following best represents how you think of yourself? Gay, heterosexual, bisexual, something else, or I don't know the answer. So how can we document disparities if we've not even raised the questions? Now we know that from 2013 to 2017, that LGB groups have nearly twice the rate of tobacco use than straight populations. Another question. We have health outcome data, and we know the scope and the magnitude of the problem. Have we used that data to direct attention to the health issues that need attention? Well, we know about the lung cancer disparities that exist between racial ethnic groups. We know that African American males have a higher incidence of lung cancer than compared to other racial ethnic groups, and it's declining, but that gap has not decreased by that much. Now, we also know from the multi-ethnic cohort study that African Americans and Native Hawaiian men and women who have lower levels of smoking have an elevated risk of lung cancer compared to Japanese, whites, and Latino Americans. So, have we been publishing data to address the issues that we see in our surveillance systems? Well, if you look at the papers that have been published from 1964 to 2018, focusing on lung cancer in black males and white males, you can see that there's a much higher rate of published papers over the years that have focused on white males and not black males. But we know the magnitude of the problem, and we know what the disparities are. And if we're not publishing the work to inform programs, then you do not have sufficient programs that focus on different population groups. I could look at the same issue focusing on income, education, and LGBT populations. For example, in 1980, there were 472 papers published on tobacco. In 2017, there were 6,279 papers. If we look at tobacco and education, 8.2% of the publications in 1980 focused on that topic, and in 2017, 17.5% of the papers focused on that topic. Again, but for some of the other groups, you don't see that. In the 1998 Surgeon General's report, Chapter 5, take another read at it. Prevention and cessation efforts in racial ethnic communities are limited by underdeveloped tobacco control infrastructures and low levels of resources for research, program development, and program dissemination. So what infrastructure exists? Well, we know that comprehensive coverage of tobacco use treatments work. Smoking among Medicaid enrollees is twice that of privately insured Americans. And we spend $39 billion each year treating tobacco smoking-related illnesses through Medicaid. We know that people want to quit, but they may not be using those resources within Medicaid to quit. But going back just a little bit more, we know that the states don't have coverage. Only 10 states covered all 9 cessation treatments for Medicaid enrollees, an increase from the 9 states in 2015. We also know that as of June 30th, 2017, 9 of the 10 states that covered all cessation treatments had barriers in place for some treatment, such as copay, prior authorization, counseling required for medicines, step care therapy, limits on duration, and annual lifetime limits on quit attempts. So, what's happening in my great state of Arkansas? I love living there, but we have some challenges. If you are not on Medicaid, you do not have access to treatment services, no matter how limited they are. From August 2018 until December 2018, 18,000 people were kicked off of Medicaid due to the work requirement in the state of Arkansas. Last Saturday, I attended a legislative session to discuss some of these issues. Of the 18,000 people who were kicked off, only 1,400 have been re-enrolled. How can we get people to quit smoking if they're getting kicked off of Medicaid? These are some of the things that we need to think about. What are the resources that are directed to research? Well, CTP, FDA has done a really good job at looking at themselves to understand what they have been funding in terms of research and the publications that have emerged. You may not be able to see all the details from your seat, but what you see is that big, tall bar is research funded on general population, and then the next tallest bar is focused on youth and young adults, and then everything else is on different racial ethnic groups, military, pregnant women, very small amount of research funded on these vulnerable groups. And you can see in the graph next to it that the publications are reflective of the research that is funded. These are things that we need to keep track of in our surveillance systems. And are we using the trajectory of surveillance information to inform tobacco policies and programs? For example, in 2003, Dr. Lawrence Kittner and Ann Hartman worked very hard to get the menthol question on the tobacco use supplement to the current population survey, which allows us to track these trends in menthol cigarette use. And we also have the question on some of the other national surveys as well, such as the National Health Interview Survey. But we know from putting the question on the survey, someone has to do it. Second of all, we can track these trends not just in general, but among all different population groups such as youth, African Americans, and other populations. And what we see here is that menthol cigarette use is increasing. But this is important, but how have we used such data? We know that data can drive policies with strong advocacy efforts because it's just not fruitful to just track the information. We have to act on it. Right here in San Francisco, Oakland, and Richmond, Phil Gardner, who I know is in the room, Valerie Yerger, Carol Magruder, and many of you worked very hard to get the flavor ban passed right here in San Francisco where we sit. This is how we use our surveillance systems for good. This is one such policy that targets a tobacco product that is disproportionately used by youth, African Americans, the poor, LGBTQ women, Hispanics, Filipino, Native Hawaiians, and many others. Now, we can monitor these policies in the same way that we have monitored smoke-free policies being implemented across states in the U.S. Lastly, why did I give this talk this title? Given the disparities we know and have known since 1964, it is time for us to revisit our surveillance goals and objectives. The speed at which we have made progress in eliminating tobacco-related health disparities is up to us. It is more than just observing the changes in various indicators across the tobacco use continuum, which you see in the first pink oval. The disparities I have come to know lies in the diversity of the leadership that's here, and you must have it to inform the conceptual framework in which you think about the work that you do. The diversity in our research enterprise must be deliberate and tracked for progress as part of our surveillance. The disparities I have come to know is embedded in the hot red oval. We are far from any levels of equity in the conduct of our research, as I showed with some of the CTP data, our resource allocation in terms of funding, our peer-reviewed publications, as I have shown examples for, our infrastructure development, and the training and health disparities research that we heard about in the Health Disparities Network meeting earlier today, and the capacity building and support for those who do the work. Equity does not mean that if I get $1 and you get $1 if you've already had 1 million. That is not equity. So, the last two thoughts I have, there's some other surveillance issues that I didn't cover, but I want to bring them to your attention. As I mentioned, we do need to continue to do surveillance of our funding initiatives, the demographics of the people who are funded, and the outcomes of that research in the peer-reviewed publications resulting from these initiatives. We want to track the type of journals that are publishing tobacco-related health disparities research. We want to track those policies, such as flavor bans, that are aimed to specifically reduce disparities, and a couple of other things we need to pay close attention to. We need to do surveillance of the levels of nicotine in products sold in low-income and minority communities. We need to continue to do surveillance of the nicotine exposure in vulnerable groups, and surveillance of changes in marketing practices targeted to low-income and minority communities as new products continue to emerge. So we need to broaden our scope of surveillance. And the last thing I want to say is that we are hosting a meeting in Little Rock that focuses on tobacco regulatory science for vulnerable and disparate groups, developing a blueprint for research policy and regulatory standards. Please contact me or email us for more information, and we're grateful for the FDA for providing funds for this meeting. Thank you very much.
Tēnā koutou katoa, ko te mea tuatai, tēnei te mea ki te tangata whenua o te wāhine, ngā mihi nui kia koutou, ki ngā tangata tuatai o te ao, tēnā koutou katoa, kia koutou katoa, i ngā reo, i ngā mana, i ngā karanga maha i huhui mai nei, tēnei wā, tēnā koutou, tēnā koutou, tēnā koutou katoa. Kia ora everyone, I'm Andrew. Before I start my presentation, I'd just like to acknowledge the original inhabitants of this place, the Indigenous peoples. Thank you. It's a tradition in where I come from that we acknowledge the people of the land and also all my colleagues who have come today. My talk is sorry, I'll just push the button. So today I'm going to talk about the New Zealand experience, the New Zealand Māori experience of tobacco control and how we've got to where we are today in terms of moving towards trying to get rid of tobacco altogether. In terms of my disclosures, I've got none to disclose. Oh, sorry, I'm pushing the wrong button. There we go. No disclosures. And what I'd like to talk about today is I'll give a brief context of New Zealand Māori, our colonisation and our politics, because it's got a lot to do with our story. I'll go over some of our story in terms of tobacco use, look at Māori tobacco control, and then reflect on our New Zealand tobacco control program, where we've got, and then some thoughts for the future. So this is where we are. For people who don't know where New Zealand, Aotearoa's, we're right down in the South Pacific. We've got a population of about 1 million people and 15% are Māori. Māori are Polynesian peoples, and we arrived in New Zealand about 700 to 1,000 years ago. In terms of colonisation, we came into first contact with Western peoples with Captain Hook in 1769. About 80 years later, because of the high rates of colonisation and the impact this was having on our people, we established a treaty with the British Crown of the time. Following that, as with many Indigenous peoples, our treaty was ignored. We faced social, economic, political disposition, and this continued right up into the 70s and the 80s when there was a lot of Indigenous rights movements and our treaty became more recognised. One thing I'd like to note is for New Zealand Māori, we didn't have any psychoactive substances used pre-colonisation. So in terms of our society, we're a diverse bunch. We still strongly associate with our tribal iwis of origin. We also have a large Māori population, 85% live in urban areas, and we have non-government organisations representing their interests as well. Our political system is an MMP system, so that means we vote for a Member of Parliament as well as we vote for our preferred political party. We have Māori political parties and we have Māori seats in committees. When I'm talking about Indigenous tobacco use, I'm talking about the experience mainly of New Zealand Māori, but also acknowledging Indigenous peoples worldwide, but also those Indigenous peoples who have experienced colonisation and who live in high-income countries. And our stories at that point sort of are similar in the sense that we all experience high rates of prevalence compared to the general population. So here on the left, 2 columns, you can see the Australian and Torres Strait Islander people's rates compared to the general Australian population. The 4 bars in the middle, we have Canadian, Inuits, First Nations and Métis populations compared to the Canadian general population. And the bars on the right, we have New Zealand Māori compared to the New Zealand population. So very big disparities. Our tobacco control program in Aotearoa, New Zealand, goes back about 30 years, and about 20 years of that has had concerted efforts around Māori tobacco control. So we've had local and national advocacy. We've had what we call Aiwahi Kore, which is smoke-free interventions. We have settings, and we focus on Māori settings and activities. We've had mass media campaigns, as well as Māori-focused cessation services. So these services are often delivered by Māori, but often for the general population of an area. Despite 20 to 30 years of tobacco control and trying to address disparities, our experience has been these disparities continue. So in this graph here, this goes from 1990 to the mid-2000s. You can see the top line is Māori smoking rates. They pretty much flatlined. The bottom line is the European other population of Aotearoa, New Zealand. So not much change over that time. And so this led to, in the mid-2000s, an intolerable situation where we weren't going to accept the impact that smoking was having on our population. We had Māori MPs like Honi Harawira proposing a bill. Shane Bradbrook here proposed what we call Tupika Kore Aotearoa, which is a tobacco-free Aotearoa. We had a huge community mobilisation around that, and in 2010 we had a Māori State Affairs Committee sort of have a hearing around the impacts of tobacco on Māori. This led to our government committing to a smoke-free 2025, which is a great thing. However, we see that the disparities continue. And so the great thing is we've had the declines in our smoking rates. Māori rates have actually started to finally come down, which is a good thing, but the rates are still hugely disparate compared to the general population. And reflecting on what we've done in the 9 years since our government committed to the smoke-free goal, we've really had we'd call a business as usual tobacco control program. So by that I mean, and it's not a criticism, is we've done the stuff that we expect in tobacco control. We've provided cessation and prioritised Māori. We've had mass media campaigns. We've focused on smoke-free settings. Standardised packaging is a huge intervention. Health warnings, and we've had annual tax increases. So these are really important. But we find that we're having ongoing disparities. And sort of to prove this point, my colleagues at the University of Otago conducted some modelling and predicted what would happen if we continue this business as usual approach into the future, with the vertical line there being our 2025 sort of end-game goal. You can see that this is Māori women compared to non-Māori women. Non-Māori women are the bottom line and Māori women are the top line, so we know what we're doing at the moment just isn't going to get close to there. Māori women will be around the goal in about 2060. And another way is this is looking at the proportion of the numbers of people we need to get to quit smoking by 2025 to achieve our goal. And so we got huge numbers here, 90,000 Māori, 220,000, huge rates. We've got a really good cessation program, I think, but the rates are far in excess of what's possible. And I think that's our elephant in the room is we've got a really good business as usual program. It does fantastic things, brings incremental change, but the change is happening too slow. So I'm suggesting we suggest a rethink in how we go about doing tobacco. And here I'm going to refer to Jeffrey Rose's classic article around sick individuals and sick populations. He talks about population level strategies, things like in tobacco control, things like mass media campaigns, tax, cessation for the whole population. These sorts of interventions might have a small impact at an individual level, but at a population level they have a huge impact. And then we have what we'd call high-risk strategies. So these are targeted for high-risk groups. So these are like our targeted cessation programs that we have for Māori women who have very high rates of smoking, targeted health warnings and so forth. Now what we've seen, as I've just shown you, is ongoing disparities. And so there's been some sort of critique over the years of, well, what causes this? And one critique has been that population strategies are utilitarian, they treat everybody the same. And so in some ways they actually privilege the non-priority groups, and that can create a disparity. Another critique is that high-risk strategies don't affect fundamental causes. Those sorts of causes are social and economic determinants that Pebbles talked about just previously. It's hard in a cessation, we're working with a young Māori woman to look at the causes that are socio-economic in origin. More nuanced or more recent literature has looked at things like, well, have we considered the agency that's required with some of these interventions? If we wonder why a person who's reasonably well off can quit compared to one who isn't, sometimes it's got to the social and economic resources that they might have at hand, and this is an issue for New Zealand Māori. So they suggest things like structural change, so looking at what the supply of tobacco is, how much it costs, where you can buy it, what's in it, its features. And then they also talk about superficial versus radical change. So superficial, we've had some great things, it's kind of a negative term, but here I'm thinking about some campaigns like attitude change that brings slow change versus radical change that will bring a big change through. Reflecting on the New Zealand program, I think we've had more of a focus on individual agency, things like cessation and mass media campaigns. Things like tax are good, but there's a lot of concern about how that might impact on Māori. And at the population level, the sorts of interventions that I've been suggesting here are more at the structural/radical end. So again, my colleagues at Bow did some modelling around this, and here we've got some modelling around the potential impact of some more what we'd call more radical type strategies. So things like the two columns on the left column is estimated prevalence in 2011, the next column across is business as usual, and then we have a bunch of potentially radical strategies. So what I'm going to say here is the tobacco-free generation has a lot of promise. Combined to end-game strategies have huge promise, and obviously the biggest promise is just getting rid of tobacco altogether, which is the flat line at the end. As part of the New Zealand arm of the ITC, which is part of the ITC that Jeff just spoke about, we've also looked at, well, what would Māori smokers think about some of these strategies? what we've found is that there's huge support for things like reducing the nicotine, i.e. getting rid of most of it, increasing the age to 21, and reducing access to tobacco. So there's a constituency of support here for these sorts of things. In terms of my conclusions, I think the first thing is that we do need our business as usual. Our traditional tobacco campaign have had huge success, but we need to extend beyond this. We need to think, what can we do that really brings about a structural radical change? These are the things that will affect our smoking disparities. We need to think about the evidence for radical structural change and structural level in-game policies, particularly for, in this case, Māori and Indigenous people, as well as other disparity groups. There's not a lot of evidence out there. There's good logic. I think we need to think about the reach and exposure and impact for Indigenous peoples. We assume they will, and we're quite confident they will, but we still need to sort of assess this. We also need to think about unintended impacts. If you introduced VLNC cigarettes, what's going to be the impact on alternatives? What's going to be the impact on cessation service demand? What are the barriers and enablers for implementing effective policies? We know that if somebody tried to introduce tobacco now, they never would, because it's such a dangerous product. There's politics behind why it's here. We need to understand the structures, what's happening, what enables it and what disables it. We need to have better evidence of upstream causes. So how does colonisation, SES, all those things impact on us? What can we do about it in tobacco control? And more closely, how does supply affect some of these things as well? And as people spoke about too, surveillance and evaluation is very, very important. The last thing I'd also like to say is, if we move from agentic, individual-focused strategies to more population-based ones, we've got to do these in partnership with, in this case, New Zealand Māori. There's going to be a partnership approach that's not done with them, it's not done on them, it's done with them. We've got to think about how they're engaged in the political formulation, the implementation, all those sorts of things. Looking at the political support, ensuring that communities are part of the intervention design, implementation and evaluation. And I sort of draw notice to the Article 4 of the FCTC here, which sort of talks about these things. And so countries have signed this. This is actually an obligation to them. Finally, I'll just refer to, at the start there was a reference to a Māori proverb that says, e tū kahakitea, and it talks about one of the tallest trees in our forests, the kakatea tree. And it gains its strength not from having a very strong root system, but by being intertwined with all the other root systems. So here, its unity is through strength. And I think from Indigenous Māori perspective, our view towards going to the future is working with and partnering with our colleagues who are experiencing similar things with our New Zealand government and also with our researchers as well. So on that note, I'd like to thank you. I'd like to acknowledge SRNT for supporting me here, my co-presenters, the ITC crew, both three, and my Indigenous research colleagues. Thank you.
Good evening. I'm delighted and honored to be here, so I'd like to start by thanking the organizers of this session, Maria, Lisa, for including me on this esteemed panel. The focus of my presentation is tobacco cessation interventions at the individual level among racial ethnic populations in the United States. When I think about individual level interventions, I kind of use an apple as the metaphor, where as we think about scaling our interventions up, many of those intervention approaches, strategies, methods are drawn from the core of the tobacco control intervention movement, which are individual level interventions. There are multiple strengths of individual level interventions, including that these are theoretically based interventions that are drawn from major psychological construct, precursors to behavior change. And a major focus of this work is not only whether interventions are successful and if they work, but how they work and under what circumstances for which individuals. Other benefits include the flexible format, so we can deliver individual level interventions in self-help, face-to-face, telephone, internet, mobile strategies as well. So they have high potential for being scaled up at the population level, and they're also ripe for implementation science studies where we're trying to investigate how we can translate these interventions into community and clinical spaces. In terms of cessation disparities, our most persistent disparity is in the comparison of African American males and females compared to their white counterparts, where African Americans are significantly less likely to achieve smoking cessation. And this has been demonstrated across studies over time. The biopsychosocial model is one way that we can begin to think about how we can impact things for individuals across populations. So this model includes the importance of multiple approaches to addressing these problems. And I'll give you a couple of examples as it relates to tobacco disparities that kind of fall in the social and psychological domains. So pharmacotherapy, we know that pharmacotherapy is recommended in any quit attempt, and we have 7 FDA-approved products to do so. We also know that certain populations, specifically racial ethnic minorities, are less likely to utilize pharmacotherapy compared to their white counterparts. So it's critical to examine possible individual level, culturally specific reasons for this underutilization, with the important note that these groups are not monolithic and that there is significant within group heterogeneity. So we conducted a review of pharmacotherapy perceptions by race ethnicity, looking at underrepresented racial ethnic minority populations. And I'll say that there were not many studies that focused on this area, and many of the studies were rich qualitative studies, which really did provide a nice context for understanding some of the possible challenges and concerns. And as you can see in the table, there were unique themes that emerged across these populations, such as African Americans discussing skepticism about pharmacotherapy effectiveness, and Hispanics who talked about a cultural conflict that exists between the need for a cessation aid and perhaps a personal weakness. So this can be something that is incorporated into interventions addressing these populations. I'll focus quite a bit on African American tobacco use because that's been my major area of study. And when you think about factors that affect this population, you can think about community level factors such as urban hassles, neighborhood environment, and you can also think of individual level factors. And what I'll discuss today is distress in terms of global distress, and then ethnic discrimination as a unique stressor in this population. So we know that stress is a major reason that people smoke. It facilitates relapse, and it's a major problem across populations. But there's evidence that African Americans and other groups experience different kinds of stress and perhaps at elevated levels. So we conducted a study where we exposed individuals to a standard group cognitive behavioral therapy and intensive treatment combined with transdermal nicotine patch therapy, and we traced them for a year to track their cessation outcomes. And what we found in this study, I was quite intrigued by. So unlike most trials that find that African Americans are less likely to quit smoking, we actually found that African Americans were more likely to quit smoking. So we wanted to understand what may be the difference in this intervention compared to others. And what we looked at were changes in perceived stress and depressive symptoms that we assessed throughout the study. And what we found is when we adjusted for, in our models, changes in perceived stress and changes in depressive symptoms, that these partially mediated this finding. So when we were able to successfully reduce the distress reported by these populations on self-report measures, that seemed to explain the greater rates of cessation. You can also think about stress exposure in biological terms, which is one nice thing about stress. You can look at it from a self-report perceived level, and then you can also look at stress and its potential to get under the skin. In the NCI monograph, we penned a chapter focused on stress exposure and tobacco disparities. And what we talked about in this chapter were that psychosocial stressors, including those that are psychological and physiological, serve to maintain smoking behavior in racial ethnic minority populations, and also ultimately the tobacco-related disease burden. And to give you an example, so this is a study where we also exposed tobacco users to a standard cognitive behavioral therapy. And in the blue lines, you have white non-Hispanics, and the red line, you have African Americans. And we assessed cortisol levels, a primary peripheral biomarker of stress and easy to measure. And we assessed cortisol over the course of, at 3 time points over the course of 2 days. And here are the ultimate findings. And I think the numbers are less important, but really what I would like you to focus on is the pattern of findings. So before exposure to any intervention, African Americans were demonstrating a flat line. And that line has been found in other studies, and it demonstrates a hyporesponsivity of the HPA axis. It's an indicator of allostatic load and the propensity for stress to get under the skin in this population. And our white participants demonstrated a more typical diurnal rhythm of cortisol, which is what you would expect. At the end of the intervention, we had also racial ethnic differences across each of our time points, where African Americans were also exhibiting dysregulation of the HPA axis. At the 1-month follow-up post the conclusion of our intervention, we also see that there are some racial ethnic differences, but by the end of the day, those lines are coming together. And although the peak that you expect to see at the second time point isn't as strong, we did see an increase where it looks a little bit more like the typical pattern that you would see. And I thought this was important because it corroborates the self-report findings that there is a difference and that perhaps this intervention might be able to reduce the disparities in tobacco cessation. So aside from global stress, we can also look at unique stressors. So racial discrimination is an example of a unique stressor that all racial ethnic populations report experiencing racial discrimination. But in this study, we looked at racial ethnic differences in the past year and lifetime racial discrimination experiences and their relationship with quit attempts. Quit attempts are important because that's an important precursor to actual behavior change. And what we found is across white, non-Hispanic, African-American, and Hispanics, that all of these groups are reporting that they are experiencing racial discrimination. Over the past year, however, you can see that the racial ethnic minorities in the sample are reporting significantly elevated experiences both in the past year and over the course of their lifetime. Also interestingly, racial ethnic minorities, particularly African Americans, reported greater distress from the experience of being discriminated against because of their race. So when we looked at that in relation to quit attempts, we found that when you look at the relationship in the bottom row of lifetime discrimination and quit attempts, the relationship is not statistically significant. But when you look at the relationship between past year or more recent discrimination and trying to quit smoking, we have an inverse association. So individuals who are reporting greater experiences with past year discrimination are less likely to attempt to quit smoking. We also see the same inverse relationship when we look at the stress experienced from feeling like you've been discriminated against because of your race, where individuals who were more stressed out by these experiences are also less likely to attempt to quit smoking. So the question is, how can we address these targets within interventions? How can we incorporate these? So that goes back to one of the fundamental questions that we've thought about for a long time in this area, is whether culturally specific interventions may confer a differential benefit. There are multiple types of health behavior change interventions that range from the standard one-size-fits-all approach to the targeting of individual populations such as pregnant women or adolescents and individually tailored interventions. I prefer the term culturally specific interventions with the recognition that these interventions are designed for a specific racial ethnic population or cultural group, but they may not actually be relevant to all members of that group. So I conducted a review of tobacco cessation randomized controlled trials over the past 10 years across our racial ethnic minority populations in the United States. So here's a summary of what I found. So in the past 10 years, there were 10 RCTs conducted focused on African Americans reporting outcomes for this group. 5 of them were described as non-culturally specific, so they could have included medication or interventions that are just designed for the general population, and 5 were described as being culturally specific. And what you can see is that one of the studies described as non-culturally specific had a differential benefit over the control condition, and one study, also in the culturally specific group, was more beneficial than control. When you look at American Indians, Native Americans, there were only 2 studies published in the past 10 years that are randomized controlled trials. And both of those were considered culturally specific. One was differentially effective, and one was a null finding. Among Hispanics, there were 7 studies conducted over the past 10 years, and 4 of them were described as non-culturally specific, 3 were described as culturally specific, and only 1 in each category were effective over the control conditions. Among Asian Americans and Pacific Islanders, there were 5 studies conducted over the past 10 years. 4 of them were described as culturally specific and 1 not culturally specific. In this case, 3 of the 5 studies did find a differential positive effect from the culturally specific interventions. So clearly, we have not done enough to address the needs of these populations. We have not perfected our science, and I would argue that there's also an art involved to developing culturally specific interventions, and I challenge us to think about how we might move forward in this area. So an example of can cultural specificity actually increase efficacy, these are data that we published from a randomized controlled trial where we did compare a time and attention matched cognitive behavioral therapy delivered in a group format compared to its culturally specific counterpart. And we followed participants for 12 months. And you might not be able to see this, but just I've highlighted 3 sessions in orange where we kind of highlight how we actually go about doing this. So we're very intentional and explicit about addressing concerns that have been identified in the literature. So we talk very, very closely about the distrust for medical research, about concerns for pharmacotherapy, about the stressors that are unique to African Americans or elevated in this population, such as discrimination and racism. We also talk about neighborhood influences in a way that is a bit different from our standard cognitive behavioral intervention. And in this case, the cultural specificity was effective. So we found a longitudinal effect of our culturally specific group compared to our standard cognitive behavioral therapy, although as you can see, even the standard cognitive behavioral therapy is beneficial in this population. But there's a differential benefit, which I think is important. So as we continue to think about how we move the needle in this area, we really want to think about meaningful approaches and ways to address tobacco disparities, and I think we need to appreciate individual differences. Level of acculturation is one individual difference that I'm very interested in, and that's the extent to which individuals adopt the practices, cultural beliefs of the dominant population. So in this case, that would be white non-Hispanics. And in this study, we randomly assigned individuals to receive either culturally specific written materials or a matched counterpart that was non-culturally specific. And what you can see is an interaction effect, where individuals, in terms of how they rated the content of the intervention and how much it impacted them, it was significantly better in the culturally specific group among individuals who reported low levels of acculturation, meaning they were more traditional in their African American cultural orientation. You had the opposite effect for the standard intervention. So it's one example that all of these interventions may not apply to all members of the group and that we should move forward in our assessment of cultural factors. I'd also like to suggest that we might rethink a bit our biopsychosocial model to include a cultural component. So this would be an example of a biopsychosocial cultural model. And cultural factors extend psychological and social factors. Although there is some overlap, there are unique things that we can possibly add to perfect the science and art of creating these interventions. So the challenge then is to strengthen the core. We need to think about new theoretical models and approaches, such as the biopsychosocial cultural approach, innovative models of minority health, and perhaps combining cultural specificity with positive psychology. We also should consider and making sure that we assess total tobacco use, including light smokers in the trials, and also study alternative and emerging projects in these populations, such as the use of black and milds or little cigars. It's also important that we are disseminating these intervention findings. We are returning the results to the communities with high need. That's highly important, and we are also making sure that we implement them across communities. If we'd like to achieve the aspirational goal of health equity, we must first address this issue of disparities. It's a complex issue and it requires a collective effort on all of our part. I think that we should take an asset versus a deficit approach as we think about cultures and cultural differences. It's also important as investigators that we really take time to know our population. And one way we can move forward on that also is by engaging community partners, not only as the people who go out on the field and conduct our studies, but who are at the table as we design and make decisions, and they own part of the work. So I'd like to end by acknowledging my many collaborators, and I also like to thank my husband because he worked hard on the design of my slides. So thanks to him also. Thank you.
Well, you're a very compliant group, and I thank you for holding your questions to the end. Don't want to keep anybody from cake and punch, but there are microphones in the center aisle, and if you have a question, we ask that you come up to the mic and direct your question to the panelists that can answer your question.
Oh, it's Donna. Oh, here.
Yes, sir.
Yes, good evening. I guess I'll get the ball rolling while people are heading out to get cake and champagne. Save me some, please. My question is for Drs. Fagan and Webb-Hooper, but I suppose all the panelists can answer if there's time. I'm curious about, well, let me first, in the interest of disclosure, I work in the humanities, so this is completely out of my range. I just want to put that out there. I'm not entirely familiar with how this works, but it's wonderful work, apparently. Would you, Drs. Fagan and Webb-Hooper, recommend interdisciplinary work as part of achieving closing the gap, the disparities in studying, tobacco control interventions, and particularly the cultural piece that you just ended with? It just sounds to me that you intimate that the problem is holistic and that interdisciplinary work might be useful in getting to that holism.
Does this work? Oh, okay. I think that's a great question, and absolutely. Certainly borrowing from other fields in the social sciences, I mean, it's an interdisciplinary problem, and so that's the level that we need to address this. Certainly medical scientists as well, in terms of the pharmacotherapy concerns. Anytime you're dealing with cultural factors, the work of anthropologists and social workers and the like, I think are hugely important to the effort.
Oh, and I'll just add that the interdisciplinary work extends to policymakers as well. That's why I brought up the Medicaid example. It's an infrastructure deficit when we don't have people on Medicaid, and the researchers, the practitioners, and the advocates have to work with departments of human services to help resolve issues that then lead us to getting people into a system where there are services to help with cessation treatment. So we do have to reach out to social institutions, policymakers, other educators, and systems such as juvenile justice systems that help us to reach additional groups and to solve the problem in a more comprehensive way. I would argue that, we have been saying for years, I've said it just like Monica just said, that it's a very complex problem. What I'm changing to and arguing at this particular point, the complex problem is not with the populations, it's with our systems and how we reach out to people to resolve the disparities. So I think that's where the complexity lies, and it requires interdisciplinary, holistic perspective.
Thank you.
Okay, I'll take this gentleman, and then you. Don't go anywhere. I see you over there. Go ahead, please.
This question is for Dr. Fung and related to policy. I just want to echo a point that came up in our Health Disparities Network meeting earlier today, which is the fact that when we evaluate policies and their impact on health disparities, we focus on the health outcomes and tobacco use outcomes, which obviously makes sense. But it's possible that policies can simultaneously be decreasing health disparities, improving health outcomes, while contributing to social injustices. And the specific example that came up was the HUD ban on smoking in public housing, and how the punitive aspects of that policy fall on a group of people that we oppress exclusively. And so the question is, how do we, moving forward, broaden our evaluation to not just say, okay, we decreased tobacco use and improved health outcomes, but to take a broader look at the costs that come along with that and how we can try to mitigate those costs.
Yeah, I mean, that's a really, really good point. I mean, the point that I made in my presentation was a fairly analytic one in the sense that the criteria that are typically used for looking at equity effects is incomplete. But what you're suggesting, and of course the disparities group is mentioning, goes beyond that, of course, with respect to what is the target and focus of these policies, and are the policies in the service of public health really leading to some sort of inequalities and suppression, perhaps? I mean, I'm a bit sensitive to this because we're here in San Francisco, and there was the the cubic error ordinance, right? They wanted to suppress Chinese, get them out of Chinatown, so they came up with this public health measure that each abode had to have a certain number of cubic feet of air for public health purposes. So you can see where that, of course, was purely targeted toward densely populated groups, namely Chinatown. So we really, I mean, you don't have to have insidious motives as that to recognize the fact that there are certain kinds of policies that are going to have adverse effects on certain groups. And we have to take a broader view with respect to what is equitable, what is fair, beyond public health, and to incorporate notions outside of public health into public health policy. So I completely agree with that.
Thank you.
Yep.
Thank you all for your excellent presentations and for elevating our conversation around these issues.
Thank you.
Hi, thanks. My name is Ginny, and I'm with the Tobacco-Related Disease Research Program here in California. And I wanted to start by thanking you for your amazing presentations. They really made concrete a lot of the things that my colleague Norval and Phil Gardner are constantly reminding us of in terms of our role in ending health disparities related to tobacco in California. So my question is, given the systemic challenges that Pebbles mentioned and the challenges of heterogeneity within priority populations that were also mentioned, are there particular interventions that you think are promising in reducing tobacco-related health disparities?
I can take it too. I appreciate the question, Ginny. And when I reviewed the literature for the past 10 years, and I saw the paucity of studies focused on racial ethnic minority populations, and then even among those that have been conducted, the low rate of those studies demonstrating success in randomized trials, I was a little bit surprised, but then not really. I think that interventions need to be designed for populations and that we need to go back kind of to the drawing board and rethink the way that we've been approaching this. There are models that I think can be beneficial. So for example, the minority stress model and others that I think possibly can be applied. But many times when you look at the studies, they're not very transparent about the way that they actually design the interventions and all the work that may have gone into it, so that we're not able to kind of have a consistent approach or really a way to understand in a systematic way which interventions are most effective. But I do think that moving forward, interventions that take a more positive approach can be beneficial. Work that I've conducted with lots of different groups, they're kind of not happy continuing to hear about the negative statistics about their groups, and they would like a different approach. And so I've been thinking more about how to incorporate more positive psychology into the interventions, just as one example.
Thank you.
Last two questions.
My name is Patricia Nez Henderson, and I've been coming to SRNT since 2006. And this is actually the first time I've seen a panel addressing health disparity at the plenary session, so woohoo! So my question is, and I've been thinking about this for a while now, in the late 1800s, the federal government put a policy in place to ban all tribes across the United States to not practice any of their traditional healing practices or any cultural practices. So it's a federal policy that was put in place. That policy was not lifted until 1978, so for over 80 years, our tribal people could not practice. However, what has happened during that time period was cigarettes were introduced. So while we couldn't smoke our plants, like Zithnut'o on the Navajo Nation or the red willow bark of the Lakota people, cigarettes were introduced into the communities, and we were able to smoke cigarettes in our ceremonies. The question I have is, how can we measure that scientifically, the impact of such policy in terms of the rates of smoking, how that's perpetuated, I guess the rates, and how we've seen the rates has not gone down, and how many studies have been done among American Indian populations over the last 10 years? 2. And I think one of the other issues that I need to really address right now is I actually want all the indigenous researchers to stand up that are here right now. So I think that is one of the issues. There's less than 10 of us in here. And in order for us to do the work that is culturally relevant, that's culturally specific, we need more of us to address this issue. So I know there's people in here that have funds, so I'm putting a pitch to you. Thank you.
You want to address?
Norval Hickman. Want to pause?
Okay. No, but hold on, Dr. Hickman, 1 second.
Yeah.
Dr. Well, you want to go ahead and answer
Sure.
the question?
Kia ora, Patricia, thanks for that. I really appreciate it. With the New Zealand Māori situation is different because we never had psychoactive substances, but we had similar acts. It was called the Tohunga Suppression Act, so it prevented our cultural practices. And then in the meantime, we had the introduction of tobacco. We didn't have we had the systems, our own systems that had been taken away from us, and so it was hard for us to respond to it. Talking from the experience of New Zealand Māori, our responses has been to do Māori or Indigenous-centred research and trying to get more funding for that, especially in the area of tobacco control and looking at it from thinking about what tobacco means from an Indigenous perspective. So when we talk about the impacts of tobacco, we're not just putting it into a medical thing, we're thinking about the whole thing, what it means in terms of colonisation, our well-being, addiction, in terms of it reflecting our emancipation from colonisation, I guess. So supporting Patricia's comment is having more Indigenous-centred research and also collaborating with other research agencies, because certainly we found there's not enough, and thank you.
All right. Norval Hickman, Program Officer with the Tobacco-Related Disease Research Program here in California. Want to just say thank you. I so super appreciate the data, the thoughtfulness that went into everyone's presentations. I think the addition of the cultural lens to the biopsychosocial model is definitely needed, it's warranted. And I also want to bring attention to it. I've been coming to SRNT since 2001. Dr. Eric Mulchan brought me in as a research assistant, and I haven't come every year, but as many years as I can. And I've seen it grow, and I think this appreciation of understanding how tobacco impacts the disproportionately impacted groups in our world, not just our communities, but globally, has grown, and that's to be lauded, definitely. But I also want to bring attention to looking in the schedule at a glance in my app that there aren't as many tobacco-related health disparities symposia and oral presentations throughout the program. And I just want to bring attention to that because I noticed that quite a few are towards the end of the program on Saturday. And it's very important for the body, the members of SRNT, to have exposure and to learn and to collaborate with folks doing disparities work in as many opportunities as possible. So it's more a comment to encourage more consideration of presenters and the good science that people on this panel are doing to go into a deeper dive into their work during the main thrust of the program. And we want to litter that, kind of spread it around throughout this conference. So just putting that out there, but to also just convey that I super appreciate and learn continually from everyone that's doing this work and try to contribute as much as I can. But just wanted to encourage that we consider it and embed and enmesh as much as possible throughout this society.
Right.
That's all.
Thank you.
So there's one person that's been patiently waiting, and so you have the last word, the last question, please.
Hi, I'm Catherine from the South African Medical Research Council, Pretoria. Part of the work I did in 2011 was looking at cultural influences for smoking in Nigeria. And my first paper from that work was titled Community Participation in Tobacco Control. So I wanted to ask if you have some ideas, because I believe that the structure for the communities, maybe outside the US, is a bit different in terms of the social political administration of indigenous communities. It's a bit different from what you have here in the US. So how would you suggest we engage the social cultural and social political leaders in communities as gatekeepers to implement some community-based interventions in indigenous communities? Thank you.
I think it's live.
Well, you know, thank you for the question. Your approach is really dependent on the community that you're working with. You know, I work with rural communities in the Delta and Arkansas, which are predominantly very poor, African American, very many low literate populations, and so you will get to know who those gatekeepers are, and those people will reintroduce you to the next level of gatekeepers. And then you begin to do community development along with your research. So for example, one of the things that we're doing with our project that focuses on reducing secondhand smoke exposure among African American women and their families is that we've written another grant to hire 2 Vistas, AmeriCorps Vistas, who will work in those counties to focus on the Medicaid issue. That then is linked to people having access to smoking cessation. So while we're doing our research study, we're also doing community development. So I'd encourage you is to think about who your audience is. That really determines what your approach is, because the same approach may not work in one community as it does in another. But I would also encourage you to think about the community development component, because I think it's inequitable for us to just go and do our research there and not identify ways to build community as we're working with them to help them become more healthy.
Thank you.
Just sorry, quickly to add to that, and our experience is to develop the trusting relationships with those communities, and for Indigenous Māori, it's also thinking about, again, from a Māori centre perspective, what tobacco use means to our culture and what role it plays in having them reflect to become champions, but primarily it's about the relationships.
Thank you.
Well, thank you. You can certainly see by our presentation. We have our answer to the question why, and I'd like to say what an honor it is to be on the dais with these talented researchers, and thank you for your endurance and your appreciation.
Let's take a photo. Yeah, and it's going to take a picture of us. Yeah, here.